Accountable care organisations are really the important infrastructure that sits around integrated working. And at the heart of this, and it's really, really important, this is about professionals on the ground working closer together, wrapping round patients in their homes, preferably, and certainly around GP surgery, and delivering more services very, very locally.
What it means is one integrated organisation responsible for healthcare in the system. It means we're able to integrate services at the point of need, and hopefully from a patient perspective they'll see a seamless service provision. So what we're doing is we're integrating core services like nursing, rehabilitation and domiciliary care. We're encouraging clinicians to work together to provide more specialist care in the community. But we're also looking at wider partnerships beyond health, such as the involvement of social care, the voluntary sector, and of course the carer and the patient themselves.
What the Accountable Care organisation is about is developing the structures and systems that will allow clinicians in real time to understand the impact that they have when they are supporting the care of an individual on the population as a whole.
Well, if we look at our plans for population health management, which we're doing at the moment, that's really predicated on the fact that we know things about patients which we capture as bits of data within computer systems. And it's then saying, well, with that information, what can we then improve and target the right sorts of services which will help patients the most?
The ACO will have 3 cohorts of patients. Those at the high end, who are already needing high intensive care, which we talked about. They will have the medium risk, so the COPD patient who's on 1 or 2 inhalers, needs exercise therapy. But then there's a whole tranche of people before who, if we get interventions done early, then we can actually prevent them becoming poorly.
There are 2 big problems, I think, and the national audit is a fantastic example of that there's huge variation in the quality of care. So we know that a patient's care, the quality they will receive, will depend very much on where they live. You might be living in an area where you get fantastic care, you might be living in an area where you're going to get really poor care, and that does not seem right. If you look at it from the hospital perspective, which is an important one to take, then it is one of the commonest reasons for emergency admission to hospital. So that's important: pneumonia, asthma, chronic obstructive pulmonary disease. If you look at it in terms of mortality and deaths for the whole population, it's really important there too. So COPD accounts for 5% of all mortality. Lung cancer is a really important cause of death, and of course at the moment still an increasing cause of death in this country. We know that asthma affects children as well as adults, so it goes right across the spectrum of age. So that's really important. In terms of costs, we know that just COPD alone probably costs the health and social care economy upwards of £1.5 billion a year.
So we're starting with, what are the problems that you currently see associated with medicines? And then thinking, okay, how can we tackle those together? Because we've got a wealth of expertise, but we just might not be doing things in the right way or the right processes.
Urgent care has been in operation for now 10 years. In that 10 years of experience, it's integrated services within themselves that have been delivered by different providers over a geographical area, and also integrated them along pathways of care. So delivering pathways, partnerships with different providers to deliver a consistent level of care across a continuous setting, so that children, families don't have a breakdown from provider to provider, or segmented care, that they can expect from us a level of care across the environments in which they need it, both in acute specialist care and into the community, and indeed in primary care.
The place that we've probably progressed furthest is around identifying levels of what we're calling frailty. That's allowed us to identify the most frail of our registered patients, and to start to work with groups of those people to consider whether our services are most appropriate, to identify proactive care that might help support these people in a different way to reduce hospital admission.
All the patient is really focused on is getting the right treatment and getting made better.
I was talking to an older lady. She had to go to PAH, and then it was Wednesday and Thursday she had appointments. And she said, I have to get a taxi because, one was for eyes and one was for ears. And why can't they do them together? And I said, yes, why not?
So the reason we're doing all this is because of the voice of the patient, and I can take it from my own personal experience as much as we can from national data. So my mum, who actually died last year, had complex medical conditions. In the hospital outpatient appointment, seeing somebody who'd be saying, "How are you doing?" And it was quite clear that none of those people were talking to each other. There was no coordination. There was no shared information, and they might actually come up with 3 different plans for my mum's care, which was, of course, a craziness. And I think in addition to that, looking at her diary over her last year of life, I think she had something in the region of 120 appointments in different hospitals and GP surgeries to go to. So her week would be totally focused around the system, asking her to come for various different bits of specialty care. So there'd be one person who'd be looking at her kidneys, there'd be one person who'd be looking at her heart, there'd be another person looking at her joints, but there was nobody really looking at the whole.
I like to think that actually this whole process has streamlined the process of a patient's journey through A&E. I was talking to somebody just this morning who had to go to A&E yesterday. They found that their experience there was really improved compared to the stories she'd heard about Harlow's A&E department. So she was really positively impressed by both the speed with which she was seen and by the courtesy with which she was dealt by the staff there.
It's about the system working together at every level, from senior management to the clinical ground, to make sure that those patients are achieving the outcomes that they would want by having access and working in the health system, so that they can live an independent and healthy life. So it's about clinical integration, but they need to have the processes behind them through management and the ACO to be able to deliver high quality frontline services to the patient. If we can make the patient journey a lot smoother and a lot less fragmented, I think that itself will introduce value into the health economy and actually improve patient outcomes.
Well, the importance of technology is making sure we're really making the most of all the innovations through IT, technology, collecting data, to say that we can really say we are using this to the maximum benefit for our patients, and they're fully engaged and able to use this technology to help manage their own conditions. The question is, how can we in the ACP bring all this together and make sure we're making the most of it for our patients?
Every patient with COPD in the GP register, I could look at 4,800 patients. I ran a couple of programs and I found very quickly that 25% of the patients on the registers weren't getting the right kind of treatment. They weren't on the right treatment pathway. I then looked at various other things to see what was going right and what was going wrong, and immediately, right in your face, you've got all this variation in care. And you can see some patients getting good care, some getting less good. And it wasn't that a particular GP was good or bad, it wasn't that a particular practice was good or bad. So I was able to use a very nice software program that is available that identifies all the patients with chronic obstructive pulmonary disease in all of the 38 practices in West Essex. It pulled out about 4,800 records. Again, anonymised, I don't know who those people are, there were no identifiers, so it's all anonymous. I could then run a very quick algorithm search which identified which patients were getting appropriate care, because we know what appropriate care looks like. And at least half the patients were not getting appropriate care. Now, that's complex, there might be lots of individual reasons for that, and I can't find that out without seeing all those patients, and that's not possible. So the next steps are going to be, how do I flag that information to the GPs and give them advice on what they might want to do about that. So that's about how we can work outside of the boundaries of our hospital physical building. Without
the first step is bringing together the pharmaceutical workforce across West Essex, which we're starting to do, and I think and we need to bring the different professions together as well. We need to be open and transparent about the myths and the perceived facts. And so we really do need to have open, honest discussions about, okay, what's the role, what's the responsibility, and really drill it out, and so that we all understand our roles and responsibilities to optimise medicines.
The way we need to try to move forward is to break down some of those walls that you were describing, and to enable the pathways that patient care follow to follow logically between the different elements of the structures that are supplying the service, so that the patient can feel that their journey is just one route.
Yes, but even that budget needs to be brought into one pot. I think you have to bring up the budget has to. If you don't do that, it won't work.
We have a multitude of different computer and IT systems, and part of the work we're doing within the CCG, as well as the ACP and across the whole of the SDP, is making sure these different computer systems can talk together.
It's very important in the current environment where all of the workforce resource feels really stretched, to understand what aspects of the work that we do really make a difference, and whether or not we can use a wider team to help us all deliver the best outcome for patients.
The take-home message is this must succeed. But not only must it succeed, I really think it will do. I think that there is a change in mindset amongst all the partners that are involved. I think the public are behind us. They understand that the finances are very tight and we have got to do this in a stepwise way. So I think that's a fair assumption and a fair way of looking at it. But I think this will succeed. In fact, I'm certain it will succeed.